Okay. All right. All right, everyone. It's November 16th. I am going to try to get through parts of Chapter 8. Blackboard is not letting me upload the PowerPoints, so I can't. I'm working on getting everyone access to the actual PowerPoints, but at the moment, I guess all I can do, unfortunately, is do the video in hopes that you can see it, supplementing your book, and obviously you guys have mastering, so you should be in that. Don't be afraid to jump ahead in the course. So there's that. All right, 1 second here. Share. Okay. All right. All right, so I grabbed some props here, and I kind of want to make sure that also that you guys, when you got this, you can zoom in on the video. I brought some stuff here, so I'm hoping that you will be able to look at it if it's at all helpful. So I want to go over some joints today, and please remember, if you're going in healthcare, we need to determine or know the difference between a sprain and a strain, all right? So remember, a sprain is usually a ligament, that's usually a joint, all right? Strain is usually muscle, that's the Sharpie's fibers where the tendon is attaching to the periosteum of the bone for the origin and insertion of the muscle, and we'll talk about that today. Another important concept and something they'll definitely be asking you, the origin is the immovable muscle, or if it's an immovable portion or bone, and insertion is the more movable, and the insertion always goes towards the origin. So now you've heard it, you're going to hear it again. So just literally just memorize that, and then figure out when you're looking at the muscles, whether it's arm or leg, and we're talking about flexion or extension, increasing the angle or decreasing the angle, determine or picture in your mind what's going on with that, right? Because those are going to be standard questions, fair game. All right, so and we'll talk today about joints and motility, synovial joints, and things like that. But please remember, usually if you're spraining, if people are spraining their ankle or whatever it happens to be, generally, not always, it's either overuse or the muscles around the area weren't strong enough. And remember also, please, that once you sprain a ligament, all right, as a connective tissue, and we talked about that earlier, we were talking a little bit about histology and tissues, that these are collagen or fibrin fibers. Once you stretch them out, they never go back. It's kind of like taking a rubber band and stretching it out, or even if you're talking about these resistance bands or whatever, once you start stretching them off for a long period of time, they never kind of go back where they were. So kind of picture that. Oh, and here we go. The fan's running and my allergies are kicking in already. Okay. All right, so let's start. So joints are also called articulations. So whenever we see articulations or something articulates with something, that means where does it touch? Where do they come together? So when you're learning these bones and joints, start realizing the articulation. So what are they butted up against? And bones just don't touch bones. So there's got to be some kind of cartilaginous structure or some kind of joint in there, whether it's a suture, syndesmosis, and we'll talk about that. There's got to be something going on there. So the site where two bones meet. Functions of joints, all right, give skeleton mobility and hold the skeleton together. So the joints, I've got a couple here, but we'll try to get this guy here, but all these joints are going to be what's giving it mobility and flexion, extension, circumduction, and we'll go over all those motions today and what they mean as far as angle and things like that. So there's two classifications. So there's always a structural and there's always going to be a functional. So structural, just start thinking anatomy, all right? Functional is more physiology. So structural is what do they look like? And then what they look like, remember, form follows function. So whatever they look like, how is it going to translate to how they function or how they operate, or what can they do or what can't they do? Or remember too, the more mobility a joint has, the less structured it is, or less sturdy it is, the more chance for it to disarticulate or sprain or strain. So, I'm sure that you all have heard of people with shoulder surgery or slap lesions, superior labrum, anterior to posterior, or rotator cuff syndrome. So the humerus and the scapula are it's relatively shallow, which gives it a lot more movement, and it's much easier to injure, or there's much more chance of overextension or injury to that due to extremes in circumduction, extension, or flexion, or whatever it happens to be. So we'll talk about the three. There's fibrous, right? And just kind of think of fibrous would be the tib fib or tibulofibular joint, or things that are just, there's not a whole lot of motion, but these two bones have to come together. So there'd be very little motion with that. Or, we talked a little bit about sutures before, and we'll go into that again. Cartilaginous, so always remember there's always going to be some form of cartilage between all joints. Not all, most. So obviously sutures don't have that. And then synovial are probably the most studied or most looked at. Your synovial joints are always going to have fluid in them. And I forgot to get my Ziploc bag full of water. Okay, I'll have to. All right, and we'll go over that. So synovial joints always have fluid. There's always a synovial fluid, and there's going to be cells that produce that. Synovium. Right. So the function, so how do they, we talked about structure and function. So 3 types based on the movement the joint allows. All right, so some are immovable, more or less, slightly or freely moving. So synarthrosis, syn usually means without, so immovable joints. All right, so that would be your sutures. Some people would say the tib fib or the pubic symphysis. There's a little bit of motion in there, so it depends on who you're talking to. Ampharthrosis are slightly movable joints, and diarthrosis are the ones that we're probably most used to, or the ones we can visualize the most. So those are freely movable joints. So structural classifications are more clear cut. So these will be used here. So the structural ones are just easier kind of to look at, and they're more clear cut for visualization. All right. So bones joined by dense fibrous connective tissue. These, there's no joint cavity. Most are immovable, depends on the length of the connective tissue. So the shorter the length of the connective tissue, the less motion there theoretically should be. The longer the fibrous tissue, the more mobility. So we'll talk about, like, later we'll talk about fibrous discs and how the, we talked about the vertebrae last week, or I did a video or 2 ago. It depends on when you viewed it or when I did it. Those have very, very short fibers, and we don't want those vertebrae to have a lot of motion. We want those discs to be slightly movable, because we obviously don't want a steel rod going up our back, but we don't want them overly mobile so that we would twist or turn or have some kind of disc herniation or facet imbrication where they jam together. So we'll talk about sutures, and when we talked about those, when we talked about the skull, and I'll try to bring this up close, because when I watched it before, it looks like you guys couldn't really zoom in. But if you look, there's a lambdoidal suture, and remember that was by the shape, right? Syndesmosis, and then we'll talk about Gomphoses, which is very specific for where your teeth, those are specific, there's a Gomphoses is what it's called. There's strictly sockets for the teeth. So sutures, as I showed you on the skull, are rigid interlocking joints of the skull. And when you're an infant, or you've all seen that, maybe, you have that fontanelle, that soft spot. You know, you don't want to push on the top of the baby's skull. And as the skull grows and ossifies, the sutures, they start locking together. And then by middle age or age 40, they generally tend to be locked. All right, there's craniosacral therapy where they claim they can get them to move. You know, it really depends. So allows for growth during youth, contains short connective fiber tissues that allow for expansion. So as the infant or toddler is growing, the brain is expanding. We need some room for that. And then while it's doing that, it's also ossifying superiorly with the fontanelle. So middle-aged sutures ossify and they fuse. So usually they're going to say 40, age 50, they're going to start to ossify or literally fuse. So there's not much motion at all. Movable joints, joint skull in one unit that protects the brain. Right. Closed and movable sutures referred to as synostosis. So when we talk about synosmosis, synostosis, if they use that term, that means they're completely immovable. And there's the sutures again. We saw that before. Remember, these are those flat bones. Are considered flat bones there. Right. Bones connected by ligaments or bands of fibrous tissue, and we'll see pictures of that coming up. I don't have a whole lot of stuff here to show you guys, unfortunately. So I apologize. So fiber length varies, so movement varies. The short fibers offer little to no movement. Example would be the inferior fib joint or tibial fibular joint. Right? So maybe I can zoom up on this. All right, laterally is the fibula, tibula, and this joint in here has fibers joining them together. All right, and up here also. So there's been a few runners that I've adjusted this on them. It kind of tends to get inflamed or whatever. All right. So longer fibers offer a larger amount of movement. Interosseous membrane connecting the radius and all along. All right. So this is super cool. So when we go from supination to pronation, you guys can see this. So there's an interosseous bone, so there's a membrane here. And as you go from supination to pronation, all right, the radius rotates. Sure, I just locked it up. Let's do this again, awkwardly. So if you can see that, it's going to literally rotate over. Right. So there is a pictorial of it, of what I just showed you. This ankle, the navicular, talus, and all that. It's just kind of this area right in here. So peg and socket joints, the Gomphoses is usually, the only thing I know of would be the teeth, the alveolar sockets. So that's specifically called the Gomphoses. Right. And then, you know, if you have scurvy from vitamin C deficiency, then the collagen, things start atrophying, your teeth fall out. And stuff like that. There's just a structure, and there's a periodontal ligament, literally anchors that in. Right? And then if you're going into dental hygiene or dentistry or whatever, you'll learn about the nerve roots and things like that. Not going to spend a lot of time on that here. So cartilaginous joints. So please remember that most all joints have cartilage. We want that hyaline cartilage, that slippery cartilaginous tissue. And a lot of these are going to have synovial fluid for lubrication and heat dissipation, right? So, you know, if you're not familiar with it, if you kind of want to know what it is, you know, unfortunately you can't come to lab here and we can't dissect anything. But literally, chicken leg. I'm going to break that apart, and you can see how those saddle joints, they glide, and there's cartilage in there. You can actually see that. Right? So bones are united by cartilage. Like fibrous joints, they have no joint cavity. So some of these don't have a joint cavity. They have a joint cavity, they're going to have synovial fluid, and those are usually ones that are going to be a lot more weight-bearing, a lot of motion with them. They're going to need that fluid. Number one, the fluid is there for heat dissipation and to reduce friction. All right. Also, though, remember, cartilage doesn't have a direct blood supply, so it doesn't heal very quickly. We have to deliver nutrients from the capillary bed, the fluid in the capillary bed. We have to get those nutrients into the tissue. So that's when you need to move a lot. So you need that pressure and movement to move that synovial fluid, but the nutrients into those osteocytes, chondrocytes and chondroblasts to get that cartilage to regenerate if it's damaged. And please remember, cartilage joints, they heal very, very slowly. So you're literally looking at minimum, usually a month to 6 months, depending on how much damage is there, because cartilage doesn't have a direct blood supply. It heals very, very slowly. So these are not highly movable. There's two types, Synchondroses and Symphyses. And when you see symphysis, you can think of the pubic symphysis, not very highly movable. I've only literally adjusted 2 of those in my lifetime, and I can tell you for the patient it was extremely painful, but the pain in the pelvic area was gone, but it's a very painful adjustment. Sidetracked. All right, so synchondrosis. All right, and remember I said chondro. Whenever you see chondro, always think of ribs, that area. Not always, but if you're taking a board exam or a test or whatever, and chondro's in there, just think rib, and if that's in there, that's probably the answer. If you don't know 100%. So synchondrosis. All right. So remember, sometimes syn means without, so you have to break these terms down. Bar or plate of hyaline cartilage unites bones. Almost all are arthrotic. Right. Syn without, arthrotic. All right, so mostly immovable. Example, temporary epiphyseal plate joints. So these are on the end of the femur, and these are growth plates generally. They're cartilaginous. They have a little bit of motion. And they become synostosis. Remember, that's without movement after plate closure. And then the cartilage of the first rib and manubrium of the sternum. And I think we talked about those last time. I can bring this guy back over. So remember, first rib, and there's that cartilage there. Right to the manubrium, sternum, xiphoid process. Remember, we kind of talked about that. All right. So there's the epiphyseal seal or epiphyseal plate, and this is the growth plate. And we'll talk about that coming up, I think. So, all right, and there's that sternum of the manubrium. Joint between the first rib and sternum is immovable or practically immovable. All right. Fibrocartilage unites bone in a symphysis joint. All right, so generally that's going to be your pubic symphysis, or of course my favorite would be intervertebral joints. All right, hyaline cartilage also presents as articular cartilage on bony surfaces. We want that glide. I don't know if I have any examples here. I did not. Sorry, guys. I did bring one, but I'm going to show you guys that tib-fib joint. Okay. Examples would be intervertebral joints and the pubic symphysis. All right. So I found this little guy here. So these intervertebral joints, all right, these really don't move. They might move forward and back. There's slight movement but we don't want them moving a whole lot, obviously. And then the pubic symphysis, right? So this glides, slight motion here. And then women, if you've had a child, you know that oxytocin in the third trimester can cause a lot of those joints, or actually all the joints in your body, to loosen up. And you want, obviously, you want that pelvic girdle to open up or be a little bit more flexible. You know, as you go through delivery, we want some motion. We don't want the we want a little bit of ligament laxity there. We don't want that to snap open or be even more painful. Says me who doesn't know, but anyway. Okay. All right, so there's just showing you the body of the vertebra, and these are very, very short fibers. Remember, we said short fibers don't allow for a lot of motion. And there's that pubic symphysis. And then we talk about the bones. You'll see the difference in the short, broader for the females and the narrower, taller for the males. Bones separated by fluid-filled joint cavities, synovial joints. And we're talking about bursars. And I was thinking this morning, I wanted to get a Ziploc bag full of water. So you can see that if you put a Ziploc bag full of water, you can actually move that back and forth. All right, that's really what a bursar is. Or if you've ever heard of bursitis, that's when people have inflammation of that. That can usually be from either overuse, or the bursar doesn't have a lot of fluid in it, so there's like a dry friction rub. It can be very, very painful. If you've ever had it or talked to someone who had it, it can be extremely painful. So all are diarthrotic, so these are freely movable. And these synovial joints have a lot more motion. Right, so they usually have fluid in them. You'll have a synovial membrane, and then there's a outer membrane with that, and we have to get some blood supply, and there will be specific cells that are going to nurture or produce nutrients for the cartilage, and we'll see that here in a minute. Characteristics of synovial joints. So there's 6 general features, all right? They have a bursa and tendon sheaths associated with them. So bursa, I said, are those little fluid-filled sacs for, like if you have a tendon or something riding over it, you want something that's movable to dissipate that heat and get rid of that friction. Tendon sheaths are where a lot of these tendons go through these conduits, all right? And if there's not a lot of fluid or they're overused, they can become inflamed and very, very painful. So if you ever heard someone who talked about a runner or somebody who's in track who had shin splints, they can be extremely painful. So generally that's the tendon it's riding in that tendon sheath, or there's inflammation, or there's not a lot of fluid, or somebody ran a race and wasn't training. So yeah, it can cause some major issues for them. Stability is influenced by 3 factors, and we'll talk about that. So stability, remember these synovial joints, you want to have, like if we're talking about the knee, we want the meniscus to generally hold those joints or the articulations in a tracking pattern. You don't want them to rotate. And you know, if we're talking about meniscus, people blow out their knee or whatever. Generally, they ran and stopped and twisted, or sometimes they just didn't really have the muscles around the knee, weren't strong enough, or could have been stronger to really hold that knee in place. And the meniscus, I've heard a lot of people, and even some doctors, you know, tell me that it's there for padding and shock absorbing. It is, but that's really not its function. Its function really is to keep the tracking of those tissues. And I have an example here, and I'll just show you guys here in a minute. All right, allow several types of movements and classify it into 6 different types. And we'll just briefly go over those. All right. So articular cartilage. So remember, articulations is where they come together. So articular cartilages consists of a hyaline cartilage covering the ends of bones. And I said before that was that blue, like glassy material. prevents crushing of the bones. All right, so cartilage is cartilaginous, so it's got a little bit of shock absorption to it, not like a meniscus. All right, and if you want to picture, like I said, like if you look at a chicken bone or whatever, or chicken leg, just if you want, break that open and take a look at that cartilaginous tissue there, and just think that's on a small bird. So imagine what that would be like in the human body. So a synovial cavity is a small fluid-filled potential space that is unique to synovial joints. So that's a potential space. So potential space is, how do I explain this? You can't actually touch it with a pin, so it's a potential space. And usually that's filled with water. So it's a space, but doesn't really contain, I don't want to say matter. Never mind. All right, so articular joint capsules are 2 layers thick. So these are going to be capsules around the joint, and they're really there for protection. We want to make sure that we don't want bacteria or microbes getting into that area too. So we have external fibrous layer, dense, irregular connective tissue. So it's very, very dense, very, very strong, relatively very, very strong. And then we have an intersynovial membrane. All right, so loose connective tissue that makes synovial fluid. So this is very important. The inner laying of those cells makes synovial fluid. And remember that synovial fluid is there for dissipation of heat and reduction of friction. And we also want to make sure that there's some form of immune function in there in case something gets in that joint space, per se. All right, so synovial fluid is viscous. All right, so viscosity is the thickness of it. So water is not very viscous. If you're thinking about motor oil, cooking oil, whatever, it's slightly more viscous. Slippery filtrate of plasma and hyaluronic acid. So literally it's coming from, I said before, it's coming from the capillary beds. So we grab the plasma from the capillary beds, it's in the blood. And remember, your blood's gonna, well, maybe you don't remember because we haven't gone over it yet. So I think that'll be AMP2, so you guys probably won't have them. But that is from blood, so it's gonna carry your glucose, all of your hormones, all of the amino acids, and we can go on to the litany of things it carries on there, but also carries your monocytes, which turn into macrophages, your neutrophils, basophils. All of the white blood cells, are all your immune cells are in there, and it's going to carry some cytokines, some chemical messengers and things. So we're going to the filtrate of the plasma is going to be in the synovial fluid. It doesn't have a direct blood supply, so we have to get that plasma and hyaluronic acid through pressure gradients and motion. We have to push it through like pushing fluid out of a sponge, not quite that easily, but I want you to maybe think of it that way. Lubricates and nourishes articular cartilage, contains a phagocytic cells to remove microbes and debris. So generally when monocytes leave your blood supply, they turn to macrophages, some neutrophils. They're going to get in there, and macrophages, macro means big, phage means eat. So these are big eaters. They're going to go in and they're going to, anything that's foreign, they don't, antigenic markers or molecular, foreign molecular patterns. They may not know exactly what it is, but they kind of know it doesn't belong there. They'll go in and just attack it. So different types of reinforcing ligaments. So we have capsular. So think of a capsule on that, all right? So thickened part of the fibrous layer, extracapsular, that's always going to be outside or surrounding, or usually if you're looking at the specimen patient or whatever, extracapsular is going to be more superficial as opposed to deep. Right? And intra always means the inside. So the intra is going to be deep to the capsule or the inside, and the capsule and extracapsular is going to be on the outside. So when we get further into this, or into A and P, you're going to talk about a cortex and a medulla. Cortex is always external or superficial. Medulla is always going to be deep or internal. Never, whether we're talking about the brain or the kidney or the adrenals, there's always going to be cortex and medulla. All right. So intracapsular is deep to the capsule, covered by synovial membrane, and kind of keep in mind that that membrane is going to be in contact with the synovial fluid, and sometimes it's going to literally generate that synovial fluid. So nerve and blood vessels. Nerves detect pain, they monitor joint and stretch. So we have nerves that give us a proprioception, which is how your joints tell your body where you are in time and space. We'll talk about that in the nervous system. All right, so we're going to send signals up towards the brain, and the cerebellum, all right, is going to tell you your balance. It's going to literally tell the cerebellum and parts of the brain through the homunculus where you are in time and space. Okay, proprioception is called. So monitor joint position and stretch, and these things you're aware of. But if you're talking about someone who plays sports or martial arts or even anything skilled, like even if you're talking about playing violin or piano, right, you're going to have proprioceptors in there are going to be able to tell, and these are learned behaviors, so we can bypass a lot of the brain structures. And you know exactly if you're playing a sport, you know, it doesn't even matter, any kind of sport, your balance, proprioception, things like that become automatic, and your joints literally tell your brain that. These capillary beds supply the filtrate for synovial fluid. So like I said, the fluid and all the nutrients or filtrate comes from your capillary beds, which is part of your blood supply. So there is, I guess, this would be, I guess, this view here, right, without all the tendons and things around it. All right, so it's basically the same thing. So this would be the capsule around this joint here. Right. So there's that ligament. Right. And it literally goes over the front, and there's a patella in here too. All right. I guess maybe we used to call it the kneecap. It's in there, but just realize here is that cartilage, and I always said it's blue. All right, there's your cartilage. There's always going to be fluid in there, and then you're going to have ligaments here for support. And then if this was a limb or an actual limb without this sagittal cut here, you'd have leg muscles: vastus lateralis, vastus medialis, rectus femoris, and biceps. Whatever. You're gonna have all those muscles in there around the leg holding that joint together too. Other features of synovial joints have a fatty pad for cushioning between fibrous layer of the capsule and synovial membrane or bone. So realize too, when you're looking at, unfortunately you guys are not going to be dissecting a cat, I don't see in the foreseeable future, but in the human body or any of these mammals, there's a fat pad, excuse me. There's fat behind your eye, in case you're going to blow to the eye. There's fat around your kidneys. There's fat all around a lot of your organs, the adrenals. They're cushioned. They're like bubble wrap to hold things in place, right? Articular disc or meniscus, right? Fibrocartilage separates articular surface to improve fit of bone ends, stabilize joint, and reduce wear and tear. So here is, this has a little flexible surface. You guys can look in there maybe. I get this out of the way. All right, so that's the meniscus. So when people, you know, say that I blew out my knee or lateral, collateral ligaments, all right, and then we'll talk about these later on and how these hold things from tracking. But really, this pad is not for, I'm pushing down on this, is not for shock absorption. It is literally, if you look in there, bursar. Okay. It's got indentations. It literally is there to hold this thing tracking so I can't rotate it. That's really its job there. So bags of synovial fluid that act as lubricating or ball bearings, all right, not strictly part of the synovial joints, but closely associated with it. So we'll see that coming up. You know, if we were talking about like this joint here, there'd be a bursar in here. So just think of a Ziploc bag that would be in there. So when you're doing your circumduction or abduction or whatever, you're constantly moving it, you're going to have that wet bursar to dissipate that heat and lubricate it. Reduce friction where ligaments, muscles, skin, tendons, and bones rub together. Tendon sheath, I said before, if you have ever had shin splints or you were a runner, or I remember probably 15 years ago, I did like step aerobics, and then I did some kind of other class with this jump rope, and we did it for like 20 minutes, and I could barely walk with her sticks. I just was not trained for that. But if the tendon sheath is moving up and down in that conduit, and like I said, if it's not lubricated real well, or you're not accustomed to that motion, or it's inflamed, it can be very, very painful when you move. Elongated bursar wrapped completely around tendons, subjected to friction. So there's really your subacromial process, the scapula. There's a humerus. This is your shoulder joint. But here, really, this is the bursar. So it's kind of, it's the same. If you look, it's, well, you can't, it's hidden there. But literally, it is a tube, and it's wrapped around itself, and there's supposed to be fluid in there. So as that tendon moves in through there, right, it reduces the friction of that. There's a bursar, and like I said, I wanted to bring in a Ziploc bag with fluid in it, so you could see how that could move back and forth. Right. Right. So 3 factors determine the shape of joints to prevent dislocation. So the deeper the joint, remember, the more stable it is, but the less motion it has. The shallower the joint, there's more motion. So we're talking about like the acetabulum, which literally means vinegar bowl. In the hip joint, it's very, very deep. All right, so that's much more stable as opposed to, if I could find it. Just give me 1 second. So there is the scapula, or your shoulder blade. Right, this would be the left. All right, because the humerus is it's very, very shallow, if you can see that. So you have a lot more motion for circumduction, but this dislocates very, very easily as opposed to the femur. So ligament, number of location. All right, so ligaments have a limited role. They really hold the bones together, but you want those intrinsic shoulder muscles to be strong so they can literally hold the humerus into the scapula. And I see a lot of, well, I see it all the time, whether it was a BAC or LA Fitness. I see these bodybuilders or whatever, or teens or whatever, and they're completely overlifting all this weight for the upper shoulder girdle because they want they want big deltoids and big traps and biceps. But what they're not doing is they're not training with lesser weights, doing these repetitive motions where they're going to build up all those muscles around that shoulder joint to stabilize it. So when they do go to lift something heavy, those muscles will contract and they lock the bone, they lock that humerus into the scapula. It's extremely important. So anyone who is listening, if you are going to healthcare, or if you're training or weightlifting or whatever, do whatever you want. But I'm telling you that you really want to start using lesser weights, you know, and not like 2 pounds either, but 10, 15, 20 pounds, do a lot of circumduction, do a lot of these exercises to get those intrinsic smaller muscles around that joint to strengthen, to really hold that humerus into the scapula. And, you know, I've had a couple students who were played softball at different colleges, and they totally agreed with me. And they said, you know, our coach always told us to do the same thing, and they just reinforced what I was just speaking of. All right, so muscle tone keeps tendons taut as they cross joints. Something important in reinforcing shoulder and knee joints and arches of the foot. All right, and remember too, your older population, and you can define older however you want. Depends on whether they're older and they were active, or they're 40 and they were inactive and that's old, or they're 60 and active and now they're starting to get old. Depends on, you know, what their lifestyle was. But remember, as you get older, all that weight, unless you're strengthening those feet, those arches that hold your foot, they start to stretch those ligaments, and then people, they get, you know, flatter feet, that arch goes, and they'll say, you know what, you know, I used to be a size 9 and now I'm a 9.5, or I used to be a 10, now I'm a size 11, because what's happening is the arches are flattening and their foot is becoming longer and sometimes wider. All right. So let's skip past that. All right, so another key point that I want you guys to just remember right now. So just write it down and put it somewhere in that cerebral cortex. All muscles attached to bone. Remember, those attached to bone through the periosteum and the Sharpie's fibers. And connective tissue at no fewer than 2 points. You can't. You have to have a connection at least 2 points. Sometimes there's one origin and 2 insertions, or, you know, there's different things. Or if you're talking about sternocleidomastoid, that's a very complex muscle. It's got all kinds of different attachment sites. The origin is always the attachment to the immovable bone. All right. Now, it can be immovable or less movable. There's always going to be an exception, but just get in your head. So generally, that's always going to be the more midline, because as we go from medial to lateral, midline to external, you know, these things move a lot more, your fingers or your toes. So usually your wrists. So usually as you go further away from the midline, they're more movable. Not always, but I'm just saying generally, the origin is usually more midline, right? Or more proximal as opposed to distal. So the insertion is attachment to the movable bone. Muscle contraction causes insertion to move towards the origin. Always, the insertion always, more movable bone always moves towards the less movable bone. There's no exception. All right, and when we talk about the cross-bridge theory coming up, we'll talk about the sarcolemma and the actin environment, or the actin fibers, myosin, and the troponin heads and things like that. We'll talk about that. Another key concept. If you're going into physical therapy or osteo medicine or whatever, it's going to be something you're going to have to know. Anyway. So movements occur along transverse, frontal, and sagittal planes. So remember, sagittal, frontal, transverse, you know, so any kind of motion is always going to be X, Y, and Z, those planes. It has to. And then sometimes you have something that's oblique, or it's not exactly in that 90th degree plane. All right, so range of motion allowed by synovial joints. And we talked about the joints before. So non-axial slipping movements over. So they're going to be just moving back and forth slightly. Uniaxial movement in one plane, biaxial movement in 2 planes, and multi-axial is movement around all 3 planes. Pretty easy. Non-axial, no axis really, just slipping movements only. All right. Uni, 1, bi, 2, multi, 3. All right, all 3 planes. And by all three planes, we just remember the sagittal, frontal, and transverse planes. So you can do more. So if you're talking about circumduction of your humerus, you're literally abduction, abduction, you do supination, pronation, all these things. Gliding, angular movements, and rotation. And then circumduction really is everything all together. All right, so gliding movements. One flat bone surface glides or slips over another similar surface. All right, so they're just really slight movements. Intercarpal joints, intertarsal. So carpal is always going to be your fingers. Tarsals are going to be your foot or toes, more or less, or between the articular processes of the vertebrae. All right, these things don't really move. They can move, glide a tiny bit. All right, you want a little bit of motion, but you don't. If you had no motion, you did something. There's someone hit you when you're in a trauma. You don't want to snap those fibers completely. You want a little bit of give. All right. So there's gliding motion. They're not really moving that much. All right, just a little bit of gliding motion. All right. Angular movements increase or decrease angle between bones. So, you know, flexion is generally always going to decrease the angle. Extension is always going to increase the angle. So if that's the 180, that's 90. All right, flexion, I'm going from 180 to 90, that's decreasing. If I'm talking about extension or hyperextension, I'm going from 180, and then, you know, we could say that's, you know, let's say what, it's 210 arbitrarily, just pick that up. Don't have a goniometer or whatever to do that. All right. Hyperextension is movement beyond anatomical position, and that you'll see some patients, you know, if they have Marfan's disease, or some athletes, gymnasts, cheerleaders, ballerinas, people in dance, they hyperextend. And like I said, when I have a new patient on the table and I'm checking things out and I just feel their spine, or I look at their posture and I'm thinking, what in God's name is going on here? And then I'm like, well, you know, if it's a guy, I'm saying, you're a gymnast, were you a wrestler, you know, there's something abnormal about that. You know, depending on the sport you played or maybe your profession, what you were doing. You know, classic example for, I don't want to be sexist, but men, I'll look at them and look at their joints or whatever, and I'm like, by chance, did you ever do construction, or were you doing drywalling where they're carrying 3 sheets of drywall on top of their head? And I'm like, what in God's name? Sidetrack, sorry guys. All right, so there's extension or hyper, you know, normally if your posture is good, your ear, external auditory meatus, should be lined up with your shoulder, with your hip, ankle, right? Good luck with that. Very rarely ever see that. But there's flexion, there's extension is back, and there's hyperextension. So depending on, you know, how your cervical spine is working and your upper thoracics, you know, depends on the amount you can do that. Right. And once again, flexion, you're decreasing the angle from 180 lower. Hyperextension, you're increasing the angle, going from 180 back further. All right, so you can figure this all out. All right, and we'll talk about pronation and supination and all of these joint movements and what their names are. So abduction, all right, movement along the frontal plane away from the midline. So if you don't remember, if somebody abducts your child, they're taking it away from you. So abduction, away from the midline. All right, AD, adding, all right, moving along the frontal plane towards the midline. So adduction is bringing it in, abduction is bringing it away. Circumduction is all of that. So if you're not sure what that is, just completely rotating your arm around, all right, is circumduction. You can do that with the humerus relatively easily, you know, unless there's, you know, shoulder joint or slap lesion or some kind of the sits muscles, supraspinatus, teres major, subscapularis. If there's an issue with that or damage or whatever, you wouldn't be able to do that as well. But barring that, shouldn't be a problem. And your hip, you can do circumduction with your hip. Generally, a lot of us have super tight adductors, adductor magnus. Sometimes the gracilis can be overly tight, and it can reduce the amount of circumduction you can actually perform. All right, so there's circumduction, abduction, adduction. All right, rotation, turning of a bone around its axis towards the midline, away from that. All right, so I showed you guys supination and pronation, where the radius and ulnar, and there's an interosseous membrane in there. So medial, rotation towards the midline, right? And lateral is rotation away from the midline. Right? Examples would be rotation of, good grief, that's C1 and C2. Now C1 is usually stable. All right, C2 is where most of your actual rotation of your head comes from, right? And rotation of the humerus and femur, right? Okay, so just realize lateral rotation is away from the midline, medial is towards the midline. So it depends on whether you're going from right to midline to left, right? You go towards midline, that's medial. Lateral is away from the midline. Supination and pronation, rotation of the radius and ulna. I showed you guys that earlier. So supination, pronation. So literally my radius, which is lateral, is rotating around. Radius and ulnar are parallel. Pronation. Palm is faced posteriorly. Radius rotates over the ulna. Show you guys that real quick. All right. Palm up, anatomical position. Radius is going to rotate around. There's a pictorial of it. Dorsiflexion, plantarflexion. Dorsiflexion's up. All right, that's going from, well, there's a retinaculum in here. All right, but that's going from flat. So we'll just say that this was whatever. So this is flat 180. Dorsiflexion's decreasing that angle. Plantar flexion is increasing it. So when you jump or do calves, or you're planting your foot to lift off, or you're stepping, you're going from dorsiflexion to plantar flexion when you push off. All right. Inversion and eversion. Inversion towards the midline, eversion is out. All right. So if you're bringing the sole of your foot towards the midline, right, or eversion would be pushing it away. So a lot of us probably can invert easily. A lot of us probably can't evert, right, as much. Protraction and retraction. All right, so you can do that with your jaw, or you can actually do it with your head. So a lot of us have forward head carriage. So if you're literally at a traffic light or whatever, instead of checking your Instagram or Twitter account or whatever I see a lot of people doing, just bring your head into retraction. So bring it back, all right, because we usually have our head in protraction all the time. So whenever you can, just bring it in retraction and just rest those with suboccipital triangle, those muscles that are constantly contracting to keep your head up, because as we look down all the time, we're stretching those out. So just bring it into retraction. All right, get rid of some of that head strain and neck tension. All right, you can do it with your jaw or your mandible. All right, maxillary is up here, mandible. You can, move it, throw it forward or pull it back. we go. Oh yeah, that's, yeah. So, oh, here it is. Okay, so let's protect the mandible back and forth, but I want you to start thinking about bringing your whole head back. You can move it, all right, forward or back. Oh, it looks ridiculous. So maybe, oh, all right, special movements. Elevation and depression of the mandible, lifting body parts superiorly, or depression. So we all do that with our scapula. You know, you can move, you can actually rotate your scapula in all kinds of, you can actually protract or retract, eversion, inversion, eversion, or whatever. A lot of us have our scapulars are elevated because the levator scap muscle is so tight because we hold all our tension there, right? So when you're contracting that, you can bring your shoulders up, and you'll realize when you're under stress, you literally clench, right? So you're wearing your scapula as earrings because it's so tense, right? Oppositional thumb, all right? Touching thumb to tips of other fingers, the same, hand or any grafting motion, all right? This is kind of what differentiates us from other animals. We have opposable thumbs. And there's elevation and depression. Opposition. And there's just a chart of these movements. So start memorizing them, writing them out, or whatever, whatever you need to do. So let's talk a little bit about some synovial joints, which are going to be pretty easy. All right. And obviously, there's not a whole lot I can test you on online. So they'll give you some kind of, like I said, all the questions are randomly generated. But they'll give you some kind of multiple choice question on this. Right. So there's a hinge joint. All right. There's yeah. So there's the olecranon. All right. There is the humerus. All right, and there's trochanter shape in there. So that's kind of a hinge joint. There's a pivot joint. It's pivoting. All right. So the radius rotates around the ulnar. So radius. Right? Remember, if you were looking at that bone here, if I had it on the lab counter, oh, it doesn't matter at this point. So I don't know if you guys can. Maybe I'll show you this guy. It's just easier. The radius there is a round circle. A radius, you remember from elementary school or maybe high school, radius is half of a circle, right? Half the diameter of a circle, the radius. That's how it got its name, right? Radius. And that's a pivot joint. It rotates, it pivots. All right. There's a biaxial motion. So that's kind of, it can rock, right? It's oval. There's a saddle joint. Trapezium, thumb, trapezium, pisiform, cunate, all those different muscle, or those different bones in the hand, all right? But trapezium, so you can do some circumduction, and you know, some people can do weird things with their hands, freakish. I guess it's really not freakish, it's just different. All right, there's a ball and socket. So this is actually shallow, the humeral head with the scapula. That is very shallow. So you have a lot more motion, but a lot more unstable. Right? Have you ever seen somebody dislocate their shoulder? You have to do the Kohler maneuver, and you have to kind of pop that back in. All right. Generally, it's a little bit painful. It just sounds a little weird. Right? All right, so I am going to upload this after I record it here. Okay, let's not give my address away here.